Hello and welcome back to the Rheumatoid Arthritis Clinically Simple series. So this will be part 2. I wasn't planning on there being 2 parts, but this will be part 2. And we were discussing about how on X-ray, how we are supposed to identify the osteopenia. So make sure to watch part 1 if you missed that. And we will simplify all of the X-ray findings, everything that is to do with rheumatoid arthritis. Now, what is osteopenia? This is a reduction. So this is kind of like a reduction in the bone. And it typically occurs with a couple of the bone and connective tissue diseases. But how are we supposed to identify the osteopenia on the X-ray? Normally, bone appears solid white on the X-ray. When it's osteopenia, there will be a reduction in the white around the joint. And you will now be seeing some areas of black. So where typically there is a solid area of white, obviously the joint doesn't look like this, but you will now see more and more black in between. And here's an X-ray just to demonstrate. Now, what about the blood tests? The blood tests in rheumatoid arthritis are key and they are very, very important, especially when it comes to the autoantibodies as well. So you have ESR, which is erythrocyte sedimentation rate. You also have CRP, you also have platelets, and these get risen. These get increased. So along with the X-ray, you also have plus, that's what I meant by plus, you also have these characteristic blood test findings. So the ESR, CRP, and platelets are increased. Hemoglobin and white blood cell count is reduced. Okay. What exactly is ESR, CRP? What does that stand for? Now, this is what I mean by simplified. This is going to be, this stuff means something, and we will just simplify it so it makes a lot more sense. Now, ESR, CRP are simply markers of inflammation, okay? And when you have these infection or inflammation, ESR and CRP will be characteristically risen. So they will be characteristically risen. Now, you will then have rheumatoid factor positive autoantibodies, which are positive in 70% of the cases. So you will not always get a positive rheumatoid factor. In fact, sometimes the rheumatoid factor can be initially negative and then positive afterwards. And this occurs in 70% of the patients. You can also get anti-nuclear antibodies, and these are positive in 30% of the case. And then you can also get anti-CCP antibodies. Anti-CCP antibodies are anti-cyclic citrullonated protein, okay? So remember, I talked about the citrullination process in the last video, but when you get these anti-cyclic citrullonated protein antibodies, this, firstly, it's not that common to get, but when it does show up as positive, that is almost certain that this is rheumatoid arthritis. Anticyclic citrullonated peptide, okay? Anticyclic citrullonated peptide. Now, if you're not aware what an autoantibody is, our immune system has something called self-detection or self-antigen. This is all to do with MHC class 1, which molecules represent MHC class 1 and which molecules don't. Now, when it comes to the rheumatoid factor autoantibody, when it comes positive, when it's positive in 70% of the cases, what is happening is the human body is producing a self-antibody, an autoantibody, and it will go and target various antigens, especially around the joint areas of the joints in the body. Now, this is all to do with the immune system not realizing that these are our own guys. If this was a criminal in a police race, then the immune system thinks that we are the criminals, our own cells are the criminals, because the immune system is kind of blind to the self-antigen because there is a lack of self-tolerance. And when you get that, that is because of the arginine being replaced by citrulline and the citrullination peptide process. All that's happening is our immune system is making antibodies to ourselves. The immune system thinks that our own cells are the criminals, okay? And that's what happens. Remember that here, the anti-double-stranded DNA. This is the anti-double-stranded DNA antibody, and this is the most specific. This is most specific for rheumatoid arthritis. Now, let's move on and go to treatment. Okay, treatment. Now, is there anything else here? No. So you are giving the patient suggestions for physical exercise and physiotherapy, but in the case of rheumatoid arthritis suspicion, then you will refer the patient to a rheumatologist so they can then administer the medications. Now, you will advise regular exercise and physiotherapy, but the rheumatologist can then narrow down if there needs to be a differential diagnosis after you already know all of these things. Anyway, if there is a differential diagnosis there to be done. What about the medications? Now, this is where it gets interesting, and this is where we can simplify things even more so. So, because this is an autoimmune disease, an autoimmune inflammatory disease, you will be using steroids, which are anti-inflammatory. So you will be using anti-inflammatory medication, steroids, either oral or intra-articular. And that's because you have such a big immune inflammation process going on. Intra-articular just means directly going into the joints. And this is typically used for acute flare-ups when the patient has any kind of acute flare-up and severe symmetrical pain. Now, you have to avoid NSAIDs in warfarin-taking patients because of drug interaction. And finally, surgery is a potential treatment. Now, what is common about all of these initial medications? This one, and here. These are all kind of symptomatic treatments. So symptomatic, I want to write symptomatic, but I have a lag in the system. So these are all symptomatic treatments. When it comes to actually modifying the progress of the disease, because remember, if you get this consecutive signs of inflammation, consecutive over and over persistent inflammation, persistent autoimmune, you will get damage of the joints and eventual loss of function as well. You won't just get stiffness, you will get damage and the damage to the joints. So we want to use disease modifying agents of rheumatoid disease, and DMARDs are your treatment of choice. These include sulfasalazine, methotrexate, and hydroxychloroquine. Okay, now before I talk about the DMARDs, I forgot to mention that whenever, this is very clinically important, whenever you use any kind of steroids, you use something that I like to call STPAC. Whoa, where's that going? You use something that I like to call STPAC. What is STPAC? Well, it's a pack of medication. So you don't give steroids on their own. You always give steroids with either a gut protectant or with a gut protectant and a bone protectant. So, okay, steroids have minimal side effects. Well, they have side effects, but the long-term side effects of steroids can cause damage to the gut and also to the bones, especially to the bones. Gastric side effects can occur with short-term use of steroids, but the steroids are known also to have research has shown to cause osteoporosis. And so you administer something I like to call STPAC, steroid pack. So you're going to administer gastric protection and bone protection with the steroids. And the medication you are going to use there is, for gastric protection, you're just protecting your gastric lining, gastric area. So you're going to give PPI or omeprazole, which includes omeprazole. And for bone protection, you're going to be using bisphosphonates. So this includes alendronate, okay, alendronate. When it comes to the DMARDs, so remember STPAC, okay? When it comes to the DMARDs, you have also, these are the ones that are actually going to be immunosuppressives. So these guys are all immunosuppressives. These are disease-modifying agents. We're actually now slowing the progression of the disease. We're trying to with immunosuppression. Sulfasalazine, methotrexate, and hydroxychloroquine. Sulfasalazine has been known to cause azoospermia. Methotrexate is known to cause oral ulcers, and you are also supposed to always do liver function tests when you are administering methotrexate, okay? Because it can cause liver toxicity. It causes liver toxicity. The other very important thing about methotrexate is that you always give it with folic acid supplements. Okay, you always give it with folic acid because it often causes a folic acid deficiency. Finally, hydroxychloroquine. Oh, this one has a big one. This one has a big side effect. A long-term irreversible retinopathy. It can cause irreversible retinopathy. So you always do eye tests in this case. Okay. So remember, most autoimmune diseases use anti-inflammatory medication, which is the steroids, and this was all symptomatic treatment. The disease-modifying agents of rheumatoid disease, arthritis, are the most important ones. Now, have a quick recap of the clinical case, of these pictures, of what it means to have rheumatoid arthritis, and what the different lab values might show. Okay, thank you so much. If you like this video, please leave a like or a comment. And subscribe to my channel. I will be making more videos for the Clinically Simple series. Thank you and take care.